Thank you very much for inviting me. Good day, everybody. Those three presentations are very fine background and introduction to what I'm going to be talking about. Next slide, please. So the silicosis, CAD for silicosis is much less developed, and the obstacles at an early phase of development, but you can see that many of the challenges are very similar to those facing the use of CAD for TB alone. Let's go on. Next slide, please. So we don't know how many silicosis cases are in the world because it's very poorly recorded and diagnosed, but we know there are extremely high prevalences in some mining areas. Southern Africa probably leads the way, but China, India, Brazil, Indonesia, and of course surveillance becomes more difficult the sort of the less developed the country. These happen to coincide in most cases with high TB burden countries. So really, when you're talking about silicosis and CAD for silicosis in a screening context, you're also talking about tuberculosis. So in Southern Africa, our mind has been focused for some years now because of the need to X-ray large numbers of miners, and particularly gold miners, because silica exposure is highest, the risk is highest in gold mining, silicosis being a fibrotic disease of the lungs. The litigation led by attorneys has resulted in a number of awards and settlements which require the finding and examination of large numbers of miners who have worked on the South African gold mines, but many of them are not in South Africa. They're in Mozambique, Eswatini, Lesotho, Botswana, and some countries further north from the old days. But the South African mines themselves, the gold mining industry has shrunk to about 90,000, but X-ray screening is in fact done in all the mines, and there's still about 400,000 working miners. So the question is, where is CAD, and this is the primary question, I suppose, from the commercial aspect, but also from the public health aspect and investment by WHO in our interest and the funders and funds, who are the potential users? So we've heard about today, on today's presentation, mining companies doing medical surveillance, compensation agencies. So South Africa has quite a well-developed but poorly functioning, I say well-developed, I mean on the statute books, poorly functioning compensation system. So the question there is finding people who are eligible. The class action suits or the litigation has resulted in trusts, which are civil agencies or private agencies, which have the same mandate. And the latest is the Chamiso Trust, which the award was 12 billion rands, about $330 million, to find all the miners who have worked for the defending companies for over the past 50 years, examine them and see their eligibility. There are and there have been dedicated centers for miners and ex-miners within the health services, usually functioning very poorly for reasons we don't go into now. But there is development in surrounding countries. And then TB programs, which is an area of development because of the investment in TB programs, are now adding the examination of miners as part of their screening. Next slide, please. So let's talk about obstacles. First of all, silicosis, we're talking about on the chest X-ray now, can be a very difficult diagnosis. Compared to autopsy, and we know this because South Africa has an autopsy system for miners and has done about 100,000 autopsies since the 70s on miners. Only about only 1/3 of silicosis shows up on the chest X-ray. Secondly, when we talk about silicosis, the number of radiological phenotypes, that's the observable representations of silicosis, vary. There is nodular, and the CAD we're going to talk about is mainly directed at identifying nodular disease, but there's also massive disease that's localized or asymmetrical conglomerate masses on the chest X-ray, and also part of other pneumoconioses. So coal workers' pneumoconiosis, for example, is a combination of silicosis and COPD, all due to dust in coal mines, and various other mixtures called mixed dust pneumoconiosis. So there is a range of phenotypes. This, of course, makes CAD development more difficult. When it comes to diagnosing as opposed to observing a nodular pattern, this is again the problem facing CAD developers. In South Africa, the main differential for nodular pattern would be tuberculosis, but there are many other causes: non-infectious sarcoidosis, cancer, other infectious diseases, fungal infection, other infections, making the differential diagnosis a local matter for which local expertise is needed. Silicosis is much more sensitive when I say sensitive, I mean sensitive to being missed or misdiagnosed with poor quality chest x-rays. Now, this was particularly a problem with analog films, and it should be disappearing with digital radiology, but it seems not necessarily to be the case. And the reason is, when you have a symmetrical nodular pattern of nodules in the x-ray, it can be very difficult to distinguish from normal bronchovascular markings. This is not the case, for example, if you have a mass in one lung or you have a pleural effusion. Sharp contrast is needed, and also you need to read these x-rays on a high standard monitor screen, otherwise you're going to make mistakes. And you know, obviously in remote settings, this becomes a big issue, and CAD hopefully can overcome this problem. And silicosis frequently occurs in combination with TB. We use the word silicotuberculosis. I'll define it later because it hasn't a one definition, and often with COPD as well. Next slide, please. Okay, so just to give you some visuals here. So what's the basic problem? Can we distinguish silicosis from normal? If you have a nice normal fixed in your mind, and you have advanced silicosis with high contrast, there's no problem. And medical students would get this right, or they would see that clearly is nodulation. But that's not usually the problem. Next slide, please. So now we have to distinguish silicosis on its own and silicosis from tuberculosis. Now, on your left is a International Labour Organization standard film, which is distributed for people to use to calibrate their eye. Now, that is a difficult film, or difficult image, should I say. It's a digital image. You're probably reaching forward to your monitors now. You probably can see that there are nodules, but maybe not. Could it be TB? So the beginning of the problem should be dawning on you. Now, the other picture doesn't look very different on the right. This is an 18-year-old boy who has never worked with silica, and he has tuberculosis. The arrows point to cavities, which start to swing the pendulum towards infectious disease, but there is in fact a nodular background. Next slide, please. Distinguishing silicosis from silicotuberculosis is also a problem facing readers in settings in which both are common. The picture on the left, in the left lung, you can see there are nodules in a particular pattern called the bat's wing or angel wing, and that's typical of silicosis. In the right, there's another disease, which, being in the right up low with loss of volume, etc., is almost certainly tuberculosis. But is it active or is it old tuberculosis? This is not a problem. This is not something you can infer from this from the X-ray. So silicotuberculosis we use to cover both active and inactive disease. The other X-ray is extremely difficult. We can see lots of nodules, large nodules of different size. There seems to be an air fluid level, possibly the filling of the cavity. Maybe there's a fungal infection in there. There's pleural thickening. Now you can, so this is a problem facing readers, and it's a problem facing CAD. And finally, of the pictures, next slide, please. Silicosis can present as huge masses. The one on the right, that's your right, our right, is a very unusual picture. There's not much that looks like that. There's absolute masses which are symmetrical. But when you get asymmetrical masses, it could really be many things, cancer, TB, and a few others. Next slide, please. The other problem with silicosis is no gold standard. Unlike TB, there's no high accuracy. Well, gold standard would have been a high accuracy reference standard that we've heard about, other than autopsy. So CT could play an important role here, and there's no question that CT is more sensitive in picking up silicosis, but it also identifies specific features, and we've seen this in the previous presentation, not seen at all on the chest X-ray. This includes adenopathy and bronchiectasis particularly, and surprisingly, I found this very surprising, masses. So I've seen a clear chest X-ray, not clear chest X-ray with just nodules, and the CT showed a mass in the right upper lobe, which was simply not visible. CT can also show different distributions, which are used to, now you need a specialist reader radiologist to make this determination. The distribution of the nodules can also give you clues. Now you're getting down sophisticated radiology, but generally CT is not available, certainly not for routine use in the settings in which I'm talking about. Reference standard relies on expert readers. The point I want to make, it needs to be a reader with local experience. And that could be a radiologist, occupational medicine physician, medical officers. But irrespective of how well trained they are, all readers, expert readers, differ in their readings, and that seems to be irreducible. Next slide, please. This is just a demonstration of how we analyze. These are two readers being compared using the Delft system. This was in our 2022 paper, and it's the receiver operating characteristic curve shows high accuracy and approximation of the readers. When you look at the actual numbers, you'll see that they're both highly sensitive if we fix the sensitivity above 90%, and with moderate specificity. So the readers can get quite close. But when that of course depends on context and the reading set. Next slide, please. The use case for silicosis, unlike the very persuasive and impactful use case you're hearing about, is not as clear. So many people who hear about AI have misconceptions about it. So they believe it's going to replace the silicosis, and particularly in a compensation environment, do better than the doctors in finding my silicosis. This is not the case. So the chest X-ray, and therefore CAD, is used for screening or triage. In other words, people of which there's no high increased probability, pre-probability, and triage for where there is some pre-probability. Diagnosis or adjudication still requires some sort of confirmatory system. Secondly, TB is a treatable disease, as we've heard. Silicosis is not a treatable disease, requiring subsequent confirmation. So what is the purpose of screening? Well, one can think of a few. In workers still exposed to silica, the question arises, which is political, industrial relations, and socioeconomic questions, removal from exposure, or, which is also an economic question, intensification of protection, which has very much been lacking in gold mining over 100 years. It's improved recently. Now, for those no longer exposed, now we're talking about the hundreds of thousands of ex-miners, really compensation, if relevant. In those who have silicosis, coming back to TPT, they should be included they are included as a vulnerable group, requiring screening for availability for preventive treatment, in which case active TB in the settings and the pictures that I've shown you has to be excluded. The impact of silicotuberculosis on expert is not, of silicosis in modifying expert results that's not been particularly studied. And the management of combined disease. Now we have two diseases. We have progressive fibrotic disease, and we have tuberculosis as a with all its post-TB manifestations. We have active tuberculosis. We've just heard about subclinical tuberculosis, and there's latent tuberculosis. It's a complex public health and programmatic problem. And the choice of threshold depends on the use case. Next slide, please. Vendor performances vary, and there are a number of vendors for TB. And as the user, as the buyer, we need to understand the source of we'd like to understand the source of the training images, the training protocol that was used, and the validation outcomes in different contexts. These need to be transparent, and we heard earlier on about the importance of transparency. And the unfortunate thing is, for some details, I'm not an expert here, somebody correct me, there's a potential clash between transparency and proprietary needs of the vendor. A recent study in South Africa compared 3 different versions of CAD for TB, 5, 6, and 7, and found significant differences on the same data set compared to radiologists, the same X-ray set. Significant differences, particularly in sensitivity, and particularly with the last version, this has been published, and accordingly, the optimal threshold. So the threshold would have to be neatly reset. Next slide, please. So that's my last slide. So what are the challenges? We've heard about, and I'm sure it's happening, the software needs to improve, make distinctions, particularly given the phenotypic spread of tuberculosis and silico-TB, question of incorporating masses, question of training. We need more clinical research, and particularly, I think, for silicosis, something to match the article by Khan, 2017, computer-aided reading of tuberculosis chest radiography, moving the research agenda towards informed policy, in which they set out a type of study design and everything to do with study and ethics. In other words, a sort of practical guide or set of criteria by which clinical validation studies should be judged. The problem of threshold shifts needs an algorithm for the local users. It's a question the user needs to ask: what threshold should I use? Operations research, we heard from my colleague that is needed. Now, that's not well funded. It seems that some funders' eyes glaze over when you use the word operations research. We're talking about everything that we've heard about today, side-by-side comparisons with actual doctors and radiographers on the ground, ease of use, connectivity, agreement with readers, but I don't mean validation. I mean agreement with the doctors using it, because if the doctors and the clinical assistants, clinical radiographers see things they don't agree with, they're going to lose faith in the CAD. And of course, the effect of outcomes and the efficiency, if it's compensation outcomes, management, fitness for work, or screening for TB in relation to cost. And we need to educate users who are dazzled by new technology. AI seems to be the source of the dazzlement. We need to shift from simply a new technology to programmatic thinking, and we've heard plenty of examples of that today, from what does it do to how exactly can we use it. And I end off with next slide, please, just publications from our particular group, but these slides will be available. You want to follow those up. The literature is generally small, but there are other studies of silicosis or pneumoconiosis. Thank you very much.